have to do with quality of life and side effects from the various treatments. Again, I apologize if you can't read all the detail on this. You don't have to. It's just the idea is that we had a group internationally of surgeons, radiation oncologists, medical oncologists, diagnosticians who said, okay, this is what we should be measuring, and these are the scales or metrics we should use to do that. So Porter suggests we should optimize around value, and he defines value as outcomes divided by costs. But what outcomes, and what should we measure? And we'll come on to that in a second. And thankfully now, having met Brendan and Eamon and others in the, Paddy and others in the faculty here, began to ask and become exposed to how does everybody else judge outcomes that are worthy in health economics, and how does that lead to policy? And it turns out we optimize on different things in value, although maybe they're the same thing. This is what we're here to tease out a little bit. We optimize on health states, for example, using cost-benefit analysis, cost effectiveness evaluation, cost utility evaluation. These are the metrics that health economists, I think, use to make these determinations of value and which is better treatment and so forth. And then we optimize on the thing that really did my head in for a few months, is this idea of utility, which I thought initially was a cup of coffee after Brendan's first lecture, but I now know a little bit more about utility, and I think it's a really key area for us as medics to get our heads around, because it really is the kind of metric of success or failure or scale that I think we can use. And when you delve into that, you find there's different kinds of utility, and it doesn't do your head wreck any good at all, but I'll come back to that a little bit later. So different people optimize around different things, and I didn't know that as a doctor. I didn't realize that this is what the health economists were advising our policymakers on. So then the question is, how do we link value-based healthcare with the more traditional health economic metrics and measurements? And that's what I'm going to try to do, which could fail miserably, but here we go. So the outcomes that you have to check when you're looking for outcomes for value, you have to know who you're working with. So first off, your patients. It's very different doing a hip replacement on a 55-year-old rugby player with a bad hip versus a 90-year-old osteoporotic female who cracks her hip, late in life. Obviously, your outcomes are going to be dictated upon the risk characterization of your patients. That has to be defined. Then each outcome has to be measured by disease. There's not one set of outcomes that's going to, even though we measure slips and falls in the hospital and line sepsis, that doesn't help a prostate cancer guy know whether he's getting the right treatment. So you have to look at the disease metrics like I showed you early on. Then you have to measure the chances of harm, which comes down to how physicians group side effects. And then the key one here, which is kind of really we're all obsessing on, is appropriately, is you have to measure what the patient considered to be a good outcome, the so-called patient-reported outcome measures, or PROMs. And finally, you got to get a handle on costs. So we did this on our own group over the last decade or so. I'm going to focus on brachytherapy, which is a type of radiation where we put radioactive sources or seeds into a prostate gland for cure. So it's a one-day procedure as opposed to 7.5 weeks of external radiation or surgery. So we looked at we've implanted about 1,300 patients here in the last 10 or 11 years. And we analyzed our first 600 patients for survival first and then for relapse. And you can see on the bottom left here, they all, thank goodness, survive. I mean, the death from prostate cancer is less than 1% because they're so early in the diagnosis. So you can't use survival as a metric to help you choose value or quality. And then we look at recurrence-free survival, and again, happily, they're all recurring, or they're all surviving quite nicely without recurrence, not all of them. If you look at their risk profiles, you find the patients with the lowest risk do very well, almost 95, 97, 98% at 5 or 6 years. The intermediate risk is in the middle curve, and then the highest risk patients are in the lower curve. So people are relapsing, but you have to know your risk profile of your patients. So then we started looking at the outcomes to do with their side effect profile, and this is the famous Florence Nightingale, and she had, obviously the PROM scales in her day were a lot simpler than the nursing uniforms, I think, she had 3 basic states. She had relieved, unrelieved, or dead, which is nice and easy, and I kind of wish we had a simple PROM scale like that now, because now we have something very different. And this is one of them, the EPIC CP questionnaire, which is the 1-page version of a 28-page questionnaire. And EPIC is only one of dozens of metrics that you could pick. This is why ICHOM, I hate to use all these acronyms, but ICHOM tried to focus us in on picking a few metrics that we could all use. But in this, you'll see that it looks at urinary, bowel, sexual, and general domains, because those are the things that are affected when you either operate or radiate patients. So we looked at our EPIC domains and we looked at our urinary domains, and we put people through a slew of patient-reported outcome metrics by paper, where they fill in I thank my team for this, they fill in the patients will put the numbers in boxes, and then we take the metrics and we analyze them, and we need biostatisticians to do that work. And we come up with mean quality of life scores, in this case around urinary function. When the curve goes up, they're experiencing problems, and when they go back down, they're actually getting better. So you can see we can show over 3 years people get temporary problems, and usually they go away. So we can get those metrics from the patients. And this is the EPIC version. And again, the 5 panels on the right-hand side refer to urinary incontinence, urinary obstruction, bowel trouble, sexual problems, and general problems. And you can see you can measure those changes. And in fact, they're statistically significant. So we're picking up real signal, and we know what's happening to our patients. That's the state of the art in the clinic. And these are 2 papers that were published on this topic in prostate cancer in none other than the New England Journal, one in 2008, and another one I'll show you in 2016, about 2 months ago. And you can see that's what they're doing. They're look at these curves. One is surgery on the left, radiotherapy in the middle, brachy on the right. And they're just basically tracking out the outcomes by patient quality of life and giving us those numbers. I think that's fine, but does that really tell patients anything? This is the more recent paper from a month ago, and we haven't moved on one whit. New England Journal, patient-reported outcome measures. This is our version of quality in 2016 in measuring quality. But how does that get back to cost effectiveness? Well, obviously, we've got to look beyond that to some degree to other metrics of quality, so we can relate this to CEA or CUA. And once you start looking at that, you come up to this great concept of the QALY, which was another head wrecker for me when I first heard about it, but I think I'm getting my head around it now. And the quality, it turns out, when you look at it, relates to what you're optimizing, and that is utility. And then utility, when you try to measure that in prostate cancer, we find, actually, I haven't done an exhaustive look, but there's very little actual measurements of utility on real patients. I could find 2 papers so far, and I'm still looking. So really, everything that you look at QALYs relates back to these a relatively small amount of data. So here's my kind of money shot here. I live or die on this slide. I'm sorry it looks awful, but this is the kind of process we're trying to go through. So we started with Porter's equation, which is outcomes divided by cost, and that's value. But then the outcome has to be a quality of life outcome, because everybody's surviving, thank goodness, so we can't differentiate on that. And the real nub of the quality of life comes from the patient, so that focuses on PROM. So quality of life equals a patient-reported outcome measure. But then you've got to take PROMs and convert them to QALYs, and QALYs relate to utility, and utility then relates to how we measure that delta in utility with the treatment. And this comes down to how do we do that? And it turns out there are methods called TTO, time trade-offs, and standard gambles. And who is actually judging these changes in quality is really important. If members of the public do it in reference to the future, they seem to overestimate the benefits or decrements in treatment. If patients do it, they seem to underestimate potentially, and people adapt with time. So it turns out this is a bit of a moving target, and how do we incorporate that into our thoughts? So here's my take home, for good or bad. I hope I'm still on time here, Brendan. If you're going to get into the business of defining qualities for anything other than cost of new drugs like the NCPE are appropriately doing, I think you have to measure QALYs that are disease, or you have to measure PROMs that are disease specific. And it's not just, you can't just lump all prostate cancer together, for example, because all prostate cancer unfortunately includes both early diagnosed, largely curable phases, and then sadly people who relapse and come back and we can't cure them and they die of their disease. They have a very different set of quality of life issues going on, so they can't be measured on with these metrics. So it has to be disease and condition specific. It has to be able to submit treatment specific, because the surgeon worries about different side effects than the radiation oncologist does. You then have to get domain specific, because we all cause differences in urinary, bowel, sexual, and general health, and they have to be measured separately. And then you've got to get into the business of how we judge quality of life and how we measure that so we can factor it into a cost effectiveness or cost utility analysis. The final bit is cost itself, and this is another gnarly topic, I realize, but if Rochelle Byrne's paper looking at cost and estimating the cost of prostate cancer in Ireland in 2010, she, as most people do, took a top-down approach, dividing it into the different phases of treatment and the different things you can do, and then looking at the total spend on healthcare and coming up with these numbers. But there is a different way to do this, and I'm glad to see Stephen Coyne with me, or here this morning, who worked with me on this in GUH, where we looked at a bottom-up approach. If we just measure everybody's time and activity engaged in treating the prostate cancer, maybe we'll get a handle on the true costs of what we're spending, what Mary has to the proportion of her budget when she decides that, or one of her doctors decides to do surgery versus radiation or brachy, how much of Mary's budget is chewed up by that decision, and is that okay? And so you can actually do this, and I'm just skip on in the interest of time to some of the work that we're beginning to do, looking at, say, the implications of deciding external beam radiation versus brachy. This is in a public hospital, so no gain to picking one of these over the other. But you can see there's a 7,500 bill to Morris Power and GUH when we pick external beam radiotherapy, and there's a 5,000 bill when we pick brachy. But the outcomes and the survivals are the same, and arguably the quality of life is the same with both. So should we be doing both? Is that in the hospital's best interest if we want to get best use for our money? So what we're doing here is using Galway patients, in real-world patients, Brendan, with prostate cancer who are getting a type of radiation, who have a very narrow focus, and trying to define a pathway that'll compare value with cost-benefit or cost-utility evaluations, and see if we can't when the Minister for Health is making a decision on new drugs in cancer or cystic fibrosis or hepatitis C, he has a very transparent process with directed well by the NCPE, and everybody knows the rules, and it comes down to, is it cost effective on that basis? And the Minister for Health can get clear guidance that the pharmaceutical companies understand and everybody understands as to whether it is or it isn't versus our budget. But nothing else in the health system gets subjected to that scrutiny, I would submit. And I think we have to, as clinicians, change that, because we've got to understand, any more than Brendan having us in health economics classes, I think as doctors we really do need to understand how policy is made and how decision makers try to grapple with these choices. So in summary, I think we can derive a cost-utility analysis, unless you tell me otherwise after this talk, and we can develop a QALY, and we can make that QALY specific to a condition, which really Porter says you have to do to define value. It must be condition focused. We should consider quality over time, because it changes. I mean, after radiation, you can get side effects that take years to evolve. And it's not just good enough to do your treatment and kick the patient back to the GP and let him deal with what happens. I do think we need to incorporate much more traditional cost-effectiveness models in our judgments in hospitals. I think most of all, patients need transparency. They need to know what's going on in each hospital in terms of real outcomes. I think the payers need transparency so that we can help them make sensible decisions. I do think we can bring competition into it, and I do think Porter's right. And I have to leave you with two quick slides. One is, if you drive from Galway to Cork, which I do a lot, and you stop for a cup of tea in Charleville, which is a good place to stop, if you go out the back of the garage, you'll see there's a car wash there. And I saw this the other day, and I couldn't resist it, because I think some of the messages that come out of our hospitals, are equally muddied. How do people know what the heck they're getting when they walk through the door? I'd like to think we can make this much more transparent, and it should be much more obvious what's really good. And I put this up in deference to the guy second from the left here, who we sadly lost a couple of weeks ago, Anthony Foley. But it should be more obvious to patients what they're getting. It should be more obvious to the payers what they're getting. And I think our challenge as doctors is to get in amongst you and try to figure out a better way to measure these things so that we can deliver better care. In closing, I just want to thank what's becoming quite a big team now, which I'm delighted to acknowledge here, the teams of people treating the patients at GOH and the Galway Clinic. Couldn't have done this without them. Rachel Lee, who helped us pull the PROM data together a couple of years ago with Brenda Dooley. Ruth Corcoran is now doing a prospective study looking at outcomes in healthcare and prostate cancer. Dawood is helping us with the biostatistics, and Dawood is here, and Brendan, Paddy, and Kieran, and all at the Health Economics for trying to clear up our thinking, which I hope we're doing. Diarmuid and Martin O'Donnell for running really terrific programs here and linking doctors with the health economists. So thank you for your attention.
Thanks very much, Frank. And so I'll move along and introduce our last speaker in this session, Benedikt Zeeman. One of the great things that's happened to me in about 6 months ago is I got instead of me emailing people, I got an email from Benedikt saying, hello, how are you? I would like to meet you and tell you a bit about myself and about the work that Benedikt is doing. And we met, and out of that meeting, at least we're still talking, and not alone that, but Benedikt is now on the program. So Benedikt is the head of business development at Median Hospital Group in Germany. He'll tell you about that group during the course of the talk itself. Before that, he worked for McKinsey, the worldwide consulting company, and worked a lot consulted a lot with the pharma sector in that role. He's got a master's degree in health economics from the University of Cologne, and as well as that, he's also got a direct interest in research in health outcomes on a PhD that he's doing. So Benedikt, please.
Guten Morgen. My name is Benedikt Simon. I'm from Berlin, Germany. I would first thank you all for coming today, and it's such an honor to be here and to talk to such a distinguished group of people, and I'm very pleased also to welcome you who are online today. I'm working for the Median Hospital Group. We are a private for-profit organization. We have about 120 clinics in Germany, and we are doing post-acute care, and I will get to that in a little while. Or maybe just starting off with that. So we call it rehabilitation, but it's not in the sense of like with working with people who have an addiction. It's mostly with people who are coming out of the somatic hospitals who would have received a new hip or a knee transplant. And we try to really suck these people out of the acute care hospitals as soon as possible, get them into our clinics, and our job is then to re-enable them to get back to work, re-enable them so that they don't have to go into long-term facilities or nursery care, that they are able to go back to their life, go back to their homes. And we are doing that, as I mentioned, for somatic patients with knee or hip replacements, for example. We are doing this also for patients with psychosomatic or psychiatric disorders, for example, depression. And we are also doing this for patients who are coming from an addiction. As I said, we are a private for-profit organization, but we're working in the German public healthcare system, so we are funded by the public health insurances and the public pension plans. So first I will give you a very brief introduction into the German post-acute care market, how this is working. Then I will briefly skim on Median, who we are, and then I will talk about real-world evidence and what this means for us as a factor in competing for patients in Germany. So the post-acute care market in Germany accounts for roughly 7% of the inpatient expenditure in Germany, and it keeps growing. And it keeps growing because of the aging population, just as it's over here. It keeps growing because of the increase of morbidity as we have new advances in medical technology. And it keeps growing because of the DRG funding that we have in the German acute care system. And I'm sure most of you are familiar with the DRG funding. It's basically a lump sum payment that the hospitals are getting for a patient. And it's incentive for acute care hospitals to discharge their patients as soon as possible. And you might want to be afraid that they would discharge the patient still being bloody, and hell, we love the bloody patients. And because we believe that we are the best to bring them back into their work environment, into their home environment, and the sooner we have the patient into our clinics, the better the outcomes will be. Another driver is just policies in Germany. We just extended the work life and It's now up to the age of 67. I don't know what it's over here, but I think they will keep bumping it up to 70 in the upcoming years. The German post-acute care market is very, very fragmented, and that's really an issue if we talk about real-world evidence, because, and that's at the bottom left, we have about 1,100, 1,200 rehabilitation clinics, post-acute care clinics, and treating about 2 million patients a year, but we have 16 patient plans who are paying for that. We have 118 public health insurances who are paying for that, and we have 43 private health insurances paying for that. And each of them are sitting on their individual data pool. So there's no chance to find out what is actually good practice in post-acute care. And on the left hand of the slide, I'm just trying to show that it's, so if you're a child in Germany and you need to have post-acute care, your health insurance will cover it. If you're in the work life, your pension plan will cover it, because it's the incentive of the pension plan to get you back into work as soon as possible. Right? And once you are in the retirement age, it's again the health insurance who's paying for it. This also leads to the fact that if for any individual patients, you might have a data pool in the health insurance as well as in the pension plan, and there's no connection whatsoever. The provider side of the post-acute care market is characterized by an oversupply. And that oversupply, you can see on the left-hand side that we have an occupancy rate of about 81, 82%. And that's not enough. It's not enough to run your business profitable. And what's interesting on that we have a higher occupancy rate in the public hospitals, but that's not because they are better, it's because public insurances streamline their patients into the public clinics, where they might actually receive better care or worse care, we don't know. Right? But that's the reason why the occupancy rate is there a little bit higher. And then you can see at the bottom that about 50% of the German rehabilitation clinics, equaling, I'm just using this synonymously, right? Or post-acute care clinics, are actually running on a deficit. So there's a high incentive on the provider side to attract more patients into your clinics. And how are we doing that? So I've said that the public pension plans and the public insurance plans, they have a tendency to channel patients into their own rehabilitation clinics. But it's actually the choice of the patient where to go. Right? And what we would like to achieve is, like, we want to engage more with the patient and showing them how much more value, as you have said it, Frank, value they can get in our clinics. And that's our strategy at the left, at the bottom there, like high medical quality based on real world evidence. There are other strategies, specializations, we are not doing that in our company. Vertical integration, like to connect acute care clinics in your own organization with rehabilitation or post-acute care clinics, we are also not doing that. We are doing economies of scale because we're the largest private profit organization in Germany doing post-acute care. And premium standards of care and low price, that's then the strategy towards the payers. So just a snapshot of who we are. We have about 121 clinics. That equals 18,000 beds and daycare places. We have 15,000 employees, and we treat around 220,000 patients a year. And our revenues are about 1 billion. We're going to hit this threshold for the first time this year after buying a couple of smaller clinics. We also actually bought just a relatively large group. We just bought 43 clinics in October, and we are integrating them. So the AHG group is now becoming a part of Median, and here you can see the public clinics that I mentioned beforehand with the high occupancy rates, that's are the DRV clinics, and they are connected to the public health insurance and mostly to the public pension plans. You can also see here how fragmented, again, the provider side is, right? Because I have only listed, I think, the top 12 providers, and you can see here they are going down with a number of facilities down to 6 and number of beds down to below 1,000, and that's actually only the top 15 provider out of 1,158 clinics we have. So as I said before, what do? We do about each and every medical indication. We do orthopedics, neurology, oncology, addiction at the bottom, and we do it for children as well as we do it for adult and elderly patients. If I'm speaking too fast, or if you have any question, please interrupt me at any point. So what's our key strategy? Key strategy number one, we want to be a national leader in patient satisfaction and quality of care driven by real-world evidence. And now what I would like you to show is what and how we work with real-world evidence and how we use that as a strategy for our organization. So there's a bunch of data out there that tells us that post-acute care is actually good for patients and it's actually cost-effective. And I've just indicated, or just would like to indicate this on 3 diagrams on the right-hand side of yours. First, for the pension funds who would, if patients were unable to work after their acute care treatment, it's cost-effective for them to send us their patients, or because only after 4 months, or already after 4 months, it's cost-effective, as it's cheaper to have the patients treated by us than to have them 4 months on the invalidity payment scheme. We are also cost-effective if you look at the cost that we have per day, comparing acute care hospitals to our rehabilitative clinics or post-acute care clinics. We are about 60% cheaper or more cost-effective than the acute care clinics. So there's a good reason for the payers to send their patients to us as soon as possible. And that might also be an idea like how you could work more cost-effective in your Irish healthcare system if you were to have similar clinics like the ones we run to a higher number to drive down costs over here. And the same is for the bottom chart. It's showing like how we are more cost-effective if you invest into geriatric rehabilitation to avoid nursing care. And that's data from, I think, 2014. So how do we arrive at real-world evidence? Then, what I have mentioned, there's a bunch of data, it's good, but we don't really know what is good, and we don't know really what clinics are good, and we don't really know what procedures are good, we just know that it's good per se. What we have established are medical boards in each section of where we provide care, and that's bringing together the chief medical physicians of all our clinics in that specialty about every 3rd month, and then we talk how we can improve our care, how we can standardize care, and how we can measure that we actually improve the care that we are giving. And that's that very distinguished group of folks who I really love to work with. And you can see we are not talking only about the standards of care, we're talking also about pharma. We're talking about which kind of pharmaceutical products we are using. We're talking about lab stuff. We're talking about what lab results do we want at what point in time, and what is useful for us and what is not useful for us. We talk about medtech, what kind of ultrasound machines we want to use, for example, and we talk about hygiene too. And we standardize this across all our clinics. So if you were a patient to come to our clinics with a new hip, you get the same care in Munich, Hamburg, Berlin, wherever you come. And you might say, well, where's the individual patient now? Right? Fair point. It comes with standardization that you can also opt to treat patients more individually, because you want to say, like, every patient is different. They are not. Right? Everybody likes to say that, but they are not. So we can have groups of patients, and we can then, if we see a patient is different than the standard patient for a hip, we can then add certain therapies, or we can take away certain therapies. And that's then the way for us to individualize care based on the standards of care that we have. But beforehand, before we had these standards, care was random. So you could have 2 sessions of physiotherapy in Munich in the first week and 1 in Berlin or 2 in Hamburg, and you didn't know what was good. But now we're starting to standardize it, and then we start to alternate now between the clinics. And then we can measure against our standards what is better care. So that's just to give you some examples. So we're looking into in the orthopedics for knee replacement, hip replacement, for patients who are coming to us after a spinal operation. We're looking in psychosomatic care for a standard for a patient with depression or chronic pain. And with these standards, we have developed, or we have taken scores which were already out there to see how our patients are doing after the treatment with us. And some of these scores are developed in Germany from other clinics, some of these scores are international scores, and some of these scores are truly developed by our physicians in these groups. And we kind of have to do that because there's not enough data out there to tell us what scores are actually telling what. Some of these scores are patient-centered, and you were talking about this as well, Frank. So what's the value for the patient? So we're asking the patient, like, how do you feel now after X amount of days with us, or how's your walking distance increase in cardiology? How's your performance? How are you doing in your daily life? Because these scores, for example, the one for the knee scale, it measures how much you can bend your knee, but that's not actually value for a patient. The value for the patient is I can walk up the stairs at home. I can do the shopping myself. That's where the value is coming from, and not how much you can bend your knee, if it's 45 degrees or 50 degrees or 40 degrees. Very funny bending your knee 60 degrees though. So when do we measure now? We measure at 2 to 4 stages during the treatment. We measure at admissions, at midstay, at discharge, and we have now developed an app that you can use on your iPhone or your tablet. And we ask the patients, like 6 months after they have been with us, to fill out the patient-centered scores again, to see how are you doing 6 months after. And that is now it's really going to make it interesting once this data is coming back, and we are just right now developing in the, I hope the dudes from IT and from our BI team, business intelligence teams are watching now online. The pressure's on, we're going to get this going, right? And it's going to be really, really exciting seeing this data coming back to us. So what are we doing? So we have this big, massive data cloud now, and we are sucking up the data from all our clinics. And I would love to tell you that we can do this for all our 120 clinics. We cannot, but we are working on it. There are some clinics that we just bought who are running their score on an old-fashioned desktop PC, and it's just sitting somewhere in the clinic. It's not connected to the intranet. It's not connected to the internet. There's no way to get access to this data from our headquarters, which is a pain. So we are working on that too. So, and what do we want to do? We want to benchmark our clinics. We want to improve our standards of care, because only if we have the standard of care and only if we measure it, we can measure, like, if we divide from the standard of care, if we walk away from the standard of care in certain clinics, if we have changes, is this better or is this worse? We are marketing this to insurances and to patients because we need the patients. We want to have more patients in our clinics. And that's going to change the post-acute care market in Germany. Just some points for discussion. There's a lack of data and a lack of research on real-world evidence in post-acute care, which is a pain, which is why we had to come bottom-up approach ourselves. And we are trying to initiate a discussion with the payers now to see, like, to show them that treatment with our facilities is actually better than in other facilities. Because so far it has been mostly a cost-driven discussion with them, and we hope to talk with them a little bit more about quality. I guess it's the same as you're doing with Novartis when you're approaching the payers now, talking about real-world evidence about how your pharmaceutical products are actually better than others. We would love to talk about pay for performance with our payers, because we believe we are doing better. We would love to talk about an integrated DIG, like an integrated funding between acute care sector and the post-acute care sector, because we believe that by bundling this together, we can streamline and really work together with the acute care clinics in their processes and in our processes. And then we really want to keep on, and that's from the business perspective now, we want to keep on the pressure on quality of care. And we are sure that we can squeeze out other competitors out of the market by attracting more patients to us. And we'll see other players drop out of the market, and that will be beneficial for patients because they are receiving better care with us, and that's going to be beneficial for our organization. So you can question a lot about what kind of healthcare system you want to have, and you were talking, Frank, also about competition in the market. And is competition good? Is competition bad? Is it bad to have a for-profit organization working in this market? Because we are working for money. We are a money-driven organization. We have a hedge fund who's supporting us. Is this good or is this bad? I think there's pros and cons to this. But coming to this, we are the ones who are driving the discussion in Germany. We believe to be doing that. And we see also some data which is collected on the health insurance side and mostly on the pension plan side. But this data we only get back 2 years after it was collected. And how good is data that is 2 years old? We have changed physician, we have changed the facilities, we have changed our standards of care. It's no good to us, so we have to come up with this ourselves. On these remarks, I would like to conclude. I hope I'm on time. I hope you enjoyed this talk. So please, if there are any questions.
Hi there. Thanks very much for all the talks. This question is really for Frank in particular. My name's Sean Gill. I'm a behavioral scientist / economist, and I just wanted to kind of challenge you a tiny bit on your presentation. So with regards to mortality, prostate screening, there's no proof over, say, a 5-year period that it actually improves mortality. And say out of every 100 people, if we take the UK and the US, one person will die from prostate cancer regardless if they're screened. But when they're screened, approximately 20 will be diagnosed or indications of prostate cancer. 2 will have either surgery or procedures that will severely debilitate their life. 18 will have ones that will minorly affect their life. So now we've 20 out of 100 that when you say you look at the quality measure, there's something called hedonic adaptation, which is the way in which you live your life, whether you win the lotto or you become debilitated, your life satisfaction and happiness tends to come back to a baseline. So the intention, like the analysis and the intention is most definitely good, but sometimes when we want to focus on process and action rather than inaction, it's very difficult as a doctor. I can only imagine when you're sitting opposite a patient and you advise against a screening, because if you tell them and then you communicate a risk to them, that they're more likely to want to take a procedure. So I just thought ask you about that really. Thanks.
So thank you very much. There's a lot in that question. I was afraid of that, but so the first point you made, I think, about screening, I suppose my talk today wasn't really to be about prostate cancer, but I do take your point. There are 2 randomized controlled trials evaluating screening with PSA currently on a population basis. One of them is showing a reduction in mortality long term. The other one is showing some equivocal results, but the feeling is that with time, that too will also show a reduction in mortality. But I take your point exactly around the whole idea of quality of life. Because when you're interceding in a disease that early, and by the way, it doesn't just apply to prostate cancer, you could say the same of breast cancer, for example. We're often accused, it's a kind of amusing in a way that as prostate cancer doctors, we're often accused of over-treating prostate cancer, but that same scrutiny is rarely applied to breast cancer approaches, which are almost identical, and the data for screening, reducing mortality is equally good or bad, depending on how you view it. So I'm certainly not here to defend the early intervention. I would say that the approach that I'm trying to promote here should also include active surveillance, because that has implications on quality of life. If you're not treating, you don't simply send the patient away. The patient has to come back for 3 monthly blood tests to the clinic, and every year to 2 years they have to undergo a repeat prostate biopsy, because that's the state of the art in active surveillance. There's a 2% rate of morbidity and mortality, and less than 2% mortality with biopsy. So active surveillance isn't a non-morbid approach either. And the psychological implications of not treating a patient also have to be factored in. So I think in prostate cancer, it's a particularly contentious issue around screening, but I was hoping the process that we're going through to look at measuring quality of life will allow us to factor those issues into the decision, and particularly will allow the patient to factor those issues into the decision, because right now it's very difficult to convey to a patient exactly what they're taking on when they take on a radical prostatectomy or radical radiation or a brachytherapy or active surveillance. And I was hoping these methods might allow us to more graphically demonstrate to a patient perhaps that data, because I don't think people get it when you put those New England Journal curves up and show people a curve that's going out on quality of life, one versus the other, for years. It's very hard I've tried showing these to patients, and it's really difficult for them to grasp what that means. And I also take your point completely on this whole hedonic adaptation and so on. I think that's really very important, and I think by bringing patients more directly into that loop, we can begin to measure how important that is, because right now they're largely excluded from it. I think we use that methodology, as best I can tell, derived from either members of the general public or general conditions, nothing to do with the prostate. So, I hope we've stimulated some discussion on this, but I completely agree that that's the point of this, is to bring the full implications of our decisions home to patients, allow them to participate in a meaningful way in the decision, and bring them also home to the payers and the insurance companies and the government, who are ultimately, and the taxpayers who are ultimately funding this whole thing. Because I think right now there's a lack of transparency in outcomes, in terms of real outcomes. So thank you for the question, Dory.
Okay, have we another question or comment, please?
Hi, I'm Vincent Jordan with the HSC's Office of the Chief Information Officer. I got a question for Mary, and Mary, I guess my question is, how much did you use information, and we're looking at real world evidence, how much did you use information that you were already collecting and actually looking at it in a new way, because you were reflowing processes? And I know that you started to capture some outcome data, but or quality metrics, as you called it.
Yeah, thanks. Yeah, no, that's a good question. I suppose as part of the whole process re-engineering piece was looking at the data that we're collecting already, and what we were seeing with the data we're collecting already, I suppose, is going back to what I've always tried to emphasize around looking at process improvement. It's not just about looking at the process. What we were seeing was it just measures basically how long people are waiting, or what's the I suppose very much the red, amber, and the green components that we're all familiar with the dashboards. But I think what we were trying to do was to get behind that. So in one way, we had to look at it, because we all know the HSC wants these metrics and we have to deliver that. But at the same time, what we were trying to do was to create our own data sets that actually gets behind, I suppose, gets under the bonnet and gets behind the numbers to see actually what other types of good quality data can we start looking at, that we'd redesign processes. Like I was looking at an article yesterday that I think, and we know that this is happening in Virginia Mason and across the States, more so now in the States, I think, than because the UK actually have done a huge amount of work on it. But where they've started like doing really dramatic things, like taking out triage out of ED altogether, taking out the line. So I think we need to start getting to that we need to, that we can limit, that we can actually reduce the non-value add, but then make the really difficult decisions. Actually, we're going to redesign the whole system. And that's the bit that I think with this 3-year piece of work that I want to get to, that's the whole redesign model.
Any other comments or questions? Pat?
Thanks very much, and thanks to all the speakers. Really interesting session. It just struck me listening to you that I guess you've all bought into the importance of real-world evidence, and it came through in each of the 3 presentations. But I guess I was just thinking of the implications for you in terms of, to analyse this data, you need a research infrastructure around you. And I guess it's for each of the speakers. Can you talk to, I guess, who does the work for you? I'm just thinking of some of our health economics graduates here coming through. Hopefully they've got their CVs with them. But even biostatisticians or epidemiologists or whoever who I guess plays that role for you.
Well, thank you for that question, Patty. So for us, we try to do it 2 ways, or I'm arguing within my organization to do it 2 ways. We have universities that we are working together with, and we are sharing our data with them on research questions, but it's not always easy for us to get our questions answered that we have, because the academia, they have their own questions and they're looking at our data with their own ideas, which is great, but it's not necessarily always that what we want. And we are now also, I'm arguing with my bosses to employ statisticians ourselves and health economists to work on our data ourselves, because I think it's something that we need to be able to do ourselves as an organization if we want to drive quality and if we want to drive real-world evidence. So I'm happy to receive CVs. If they say that you speak German, because our data is in German. The numbers are not, the numbers are in Arabic, but the titles on the columns are in German, so there has to be some proficiency in German.
So I think it's a great question. So what we're doing is we're collaborating with the university, and we have 3 PhD students, one in health or population health, one in biostatistics, and we've just recruited someone with, thanks to the Galway Clinic, I see Joe O'Donovan up there supporting us recruiting a business intelligence analyst who's with us today to help to try and put this data into formats that I think we can use. But I think you're touching on a really important point. I think the problem that is very labor intensive from 2 perspectives. One from the clinical team, who already feels themselves overburdened, right or wrong, but secondly from the patients. We're bombarding the patients now with a myriad of quality forms, patient satisfaction forms, quality of life output forms, you name it, we're coming at them from all angles, and they're not easy to fill. Sometimes they take time, they involve a bit of soul searching on the part of the patient. So I think that there's a real issue about us overdoing it with patients in terms of some of this data around quality of life, but that's the way it is at the moment. I think personally we have to change our information technology systems from the ground up and from the front to the back. I think even if you have very sophisticated electronic medical record systems in your organization, what you'll find when you go back to look at the data is it's in PDF form, or it's in forms that really are not suitable for analysis. And the kind of analysis we require for this data is the quality of the work is the sort of work you'd need to have to publish in a peer-reviewed journal, which is going to require structure, biostatistical evaluation, and so on. So, all help welcome. I think academic from collaborating with our partners in university, but I think we have to take a real look at the culture in the healthcare organization and change it from the ground up. I think, and then we need to use electronic systems with apps and various other devices to bring the data straight into an evaluable format from the patient directly, because trying to have them fill out a form, the form goes in a drawer, it's taken out, has to be abstracted, put into a different format, analyzed with SPSS, biostats work done on it, then back to the clinician, goes round and round, costs time and money, and is very inefficient. So a key thing, we're bootstrapping this at the moment, but it needs to be, I think, done differently.
Yeah, and I suppose just from ourselves, I think that's a good question as well. And I think it's as Frank said, I think coming from the hospital delivery system, I think we see that we don't have an army of data analysis within the hospital. And what we saw in the projects that we were delivering, that's a huge amount of data. Now, we did actually bring in somebody that had actually trained process improver, but actually concentrated on the data. But it did open a question to us in relation to how do we engage with our university partners to change, I suppose, the infrastructure of how we collect data in the hospital system. And UCD have insight, and really what we're trying to do in the group is trying to partner with Insight to bring the insight out into the hospital side, but also get the hospital side looking at actually from the university point of view. And there's a good program of work going on in Southampton at the moment where they have a joint post between the hospital and the trust, and they actually